I'm going to simply share my experience, very much our regional and to some extent UK perspective of managing babies and children with antenatally detected hydronephrosis. In the UK, all pregnant mothers are offered 2 routine antenatal ultrasound scans. The initial scan is done between 11 and 14 weeks of gestation. This is called a dating scan and is done primarily to estimate date of delivery. It also checks whether mom carries a single or twin pregnancy. The second scan, otherwise called a fetal anomaly scan, is carried out between 18 and 21 weeks of pregnancy. They look for 11 specific anomalies, and renal anomalies account for 17% of all anomalies. Of that, 50% contribution comes from hydronephrosis. The fetal renal pelvis can be measured in 3 different planes: anteroposterior, transverse, and longitudinal. For standardization and consistency, anteroposterior diameter of the pelvis measured in the transverse plane is always quoted. Renal pelvis becomes visible when anteroposterior diameter is 2 mm or greater and fluctuates due to various factors, including how full the bladder is. So when do we call the visible pelvis abnormal and brand it as hydronephrosis? Although there is no general consensus, most fetal medicine specialists quote 5 mm before 30 weeks of gestation and 7 mm after 30 weeks as upper limit of normal. Greater than 10 mm is considered significant and warrants postnatal investigations. Of course, imaging plays a very important role in the postnatal evaluation of these children, and the ultrasound scan is the primary modality. Next in line are radioisotope investigations, such as MAC3 venogram and DMSA renal scintigraphy. Although both investigations estimate the differential renal function effectively, DMSA would be more appropriate to look for cortical abnormalities such as scars, and MAC3 is needed to assess drainage across the PUJ and VUJ and to look for vesicular reflux in indirect cystogram in potty-trained children. NCUG, as you all know, is the gold standard to diagnose vesicular reflux and provides excellent anatomical and functional information regarding bladder, bladder neck, and urethra. MR urography is reserved for complex urological anomaly when above-mentioned investigations failed to provide the necessary information for appropriate management. When we look at the etiology of this antenatally diagnosed hydronephrosis, pelvic junction anomaly is by far the most common cause. A majority of them appear to resolve without the need for surgical intervention while monitoring antenatally and postnatally, and they are referred as transient hydronephrosis. Differentiating this group from clinically significant PUJ obstruction was a challenge in the past, but thanks to some wonderful longitudinal studies, we have a broad consensus on indications for surgical intervention. The other causes include vesicular reflux in 10 to 20%, vesicular junction obstruction, otherwise called obstructed megaureter, in 5 to 10%, multicystic dysplastic kidney, posterior urethral valves, and duplex kidneys in smaller proportion. As you see, I have here put them into 2 separate groups. Those who are in the first group warrant immediate postnatal evaluation and potential surgical intervention before leaving the hospital, whereas the babies in the second group could be discharged home with antibiotic prophylaxis commenced on day 1. They also need the postnatal ultrasound scan organized to be done between day 3 and day 14. Based on these scan findings, further follow-up ultrasound scan with or without a functional scan will be obtained from 6 weeks to 3 months. Let us look at each one of these conditions and their management briefly. Um, a baby boy with a history of bilateral hydroerythronephrosis or a solitary kidney with hydroerythronephrosis on a third trimester antenatal ultrasound scan has posterior urethral valves unless proved otherwise. I personally do not think a postnatal ultrasound scan makes very much difference apart from as a baseline. The treatment of the newborn should begin with antibiotic prophylaxis, bladder drainage by urethral catheter, correction of fluid and electrolyte balance, and micturating cystourethrogram under antibiotic cover when baby is stable. When the diagnosis is confirmed, plan for endoscopic ablation of valves with circumcision carried out either at the same time or at a later date. You all know the importance of long-term management, and I'm sure Dr. Ramesh Babu will talk about it a little later. Now, moving on to the next etiology, that is, or diagnosis, ureterocele. Although not all babies need emergency treatment, we need to be aware of the potential bladder outlet obstruction causing damage to otherwise normal contralateral kidney and risk kidney sepsis. Urgent transfer to tertiary center and puncture of ureterocele cannot be overemphasized. Here is a baby girl with prolapsing ureterocele presenting as interlabial mass. Let's look into the anomalies not in need of urgent management, starting with PUJ obstruction. Sometimes, as in this case, you see a baby with postnatal ultrasound scan showing gross pelvic LCL dilatation with normal contralateral kidney. There were no visible ureters and bladder was unremarkable. As you figure out, the diagnosis is severe PUJ obstruction, although possibility of a multicystic dysplastic kidney could not be ruled out. Rather than waiting for renal maturity and obtain diuretic mercury renogram in 6 weeks or so, we simply carry out a DMSA renal scintigraphy and proceed with neonatal pyeloplasty if the ipsilateral kidney has any function at all. And as you can see, this particular image shows severe pelvic LCL dilatation with AP pelvis measuring greater than 6 centimeters. However, more commonly you have babies with pelvic LCL dilatation, with PUJ configuration and AP renal pelvis measuring between 10 millimeter and 40 millimeter. As I said earlier, good number of clinical studies in the last 3 decades have helped us to have an idea to select candidates for surgical intervention. So we know majority would need pyeloplasty if anteroposterior renal pelvis is greater than 30 millimeter, less commonly when AP diameter is between 15 and 30 millimeter, and less than 2% if anteroposterior renal pelvic diameter is less than 15 millimeter. Gita Dillon and Hutch Dillon at Great Ormond Street Hospital in their longitudinal study identified about 2% of this population still underwent pyeloplasty, where the renal pelvic diameter did not appear to increase. However, there is the pelvis is intrarenal and there is significant LCL dilatation. In cases where you have significant pelvic LCL dilatation, if a diuretic mercury renogram shows a differential function of less than 40% with poor drainage, then of course baby would need a surgical intervention. Now, clinician's judgment should never be just based on a radiologist's report, but their own ability to read and interpret these investigations. And of course, if baby becomes symptomatic, the decision is made easier. Anderson-Hines dismembered pyeloplasty has stood the test of time and remains the preferred technique in babies and children when they undergo primary pyeloplasties. Moving on to the next, megaureter, all it means is just a dilated ureter. although commonly referred by clinicians to imply obstructing megaureter, otherwise called PUJ obstruction. And I'm sure you may be familiar with Smith or King's classification of the megaureters. It could be refluxing, obstructed, non-obstructed, non-refluxing, obstructed, and refluxing. They can be primary when the lesion is intrinsic PUJ anomaly, or secondary when the pathology is extraluminal, such as dilated ureters seen in post-urethral valves or neuropathic bladders. Here is an example of primary refluxing megaureter, and the first line of management is always medical. Breakthrough febrile urinary tract infection, in my book, is the only absolute indication to consider surgical intervention. There are some relative indications and some debatable indications, and I will leave this to Dr. Arun Srinivasan to talk about it, hopefully soon. Now, here is an image and MAC3 renogram pictures showing an obstructed megaureter. It is important to keep in mind about 70% of non-refluxing megaureters resolve with time without the need for surgical treatment. The indications for surgical intervention include, as for PUJ obstruction, poor function on the ipsilateral side, symptom development, and progressive dilatation. Ureteric reimplant is the definitive procedure, although carries significant morbidity in less than 1-year-old babies. In this situation, and in acute urinary sepsis, other temporizing measures such as cutaneous endurotomy, side-to-side refluxing ureteroneocystostomy, or nephrostomy is considered. Regarding multicystic dysplastic kidney, although the terminology implies a histological diagnosis, it is indeed a radiological diagnosis. If ultrasound scan shows typical appearance and DMSA renal scintigraphy confirms no function on the ipsilateral side, the diagnosis is confirmed in 93%. If diagnosis is in doubt, that itself is one of the very rare indications for pyeloplasty. And hence nowadays, they are all treated conservatively by the pediatricians and the nephrologists, although some clinicians would say there are selective reasons for them to carry out nephrectomy. However, we have no strong evidence for the practice of routine removal of MCDK any longer. Now, about duplex kidney, if an antenatal ultrasound scan did show a duplex kidney, but neither mites are not dilated, or shows any ureteric dilatation or ureterocele, then it is an uncomplicated duplex kidney. It does not warrant postnatal investigations or monitoring. It is inconsequential. However, when either upper or lower or both mites are dilated, it is referred as complicated duplex and warrants postnatal investigations, careful monitoring, and surgical management as listed here. And the picture on the top is a case of bilateral duplex kidneys with poorly functioning upper mites. The picture in the bottom is a retrograde parallelogram showing a duplex kidney with lower mite dilatation secondary to reflux and unaffected upper mite. I'm not going to go through each of these procedures in detail, but of course, in the best interest of limited time, I'm going to move on to the ectopic ureters. Ectopic ureters from a duplex kidney is much more common than simplex kidney ectopic ureters. Nowadays, it is usually picked up on the antenatal scans, but in the past, it is diagnosed commonly when girls present with urinary incontinence. In boys, the ectopic ureter never causes urinary incontinence. Boys can present with epidermitis. The investigations and surgical management are as listed here. And I find ipsilateral laparoscopic assisted ureterostomy a less risky but very effective procedure. Sometimes the diagnosis can be difficult enough to warrant complex and sophisticated investigations, including MR urography, and sometimes you have to do a general anesthetic and carry out a cystovaginoscopy to aid us to diagnose appropriately and carry on with right management. Always think about potential bladder outlet obstruction. Managing babies with antenatal hydronephrosis is a significant proportion of every pediatric urologist practice. And managing these babies and children is not always science or straightforward. Although we have made wonderful progress in identifying these babies at risk, there is still limitation in evidence base. Personal experience of the individual surgeon and their clinical judgment plays a major part in decision making. Thank you very much.